30 seconds. Okay, everybody, we're about ready. 5, 4, 3, 2, and go.
Greetings and salutations. Welcome to the 6th installment of the 21st year of Demystifying Medicine, the course whose goal is to bridge exciting developments in biology and engineering with medicine. I'm Dan Kastner. I am the Scientific Director Emeritus of the National Human Genome Research Institute, and I will be your host this afternoon. Our usual host and the father of the course, Dr. Win Arias, is off gallivanting today, and he asked me to fill in for him. As you all know, the purpose of this course is really to establish a dialogue between the worlds of biology and engineering and medicine, and that dialogue crackles every Tuesday afternoon from 4 to 6 in the afternoon from January 4th to May the 3rd. Of course, you can tune in by videocast at the link shown on the screen. The course schedule is also available to you. And those of you who attend at least 50% of the sessions, which is about 10 of them, and pass a final exam will receive a certificate. Now, today we don't have a CME number because apparently something fell through the cracks in terms of disclosures. But next week, we will be offering CME credit. And the talk today the talks are so riveting that I am sure you will want to stay regardless of whether there is CME credit. So in any case, just the drill, as we always have it, is that for any of you who have any questions while you're watching this presentation, please just use the send live feedback option on the videocast display. And those questions will come to one of my colleagues and they will be fed to me and I will pose them at exactly the right moment. Any of you who want to see any of the previous sessions, they're all archived going back 21 years, and the link for that is shown on this slide. And for additional information, there's the email address for the gallivanting Dr. Arias. If we could have the next slide, please. I'd like to just show you a picture taken by Dr. Arias's grandfather with a box camera of the construction of the Brooklyn Bridge. And for those of you who don't know, the Brooklyn Bridge goes from Manhattan in New York to Brooklyn, and it was built between 1869 and 1883. And here you see in this picture, actually 2 men who are on a catwalk. You can see to the left. One of them walked over from Brooklyn and the other from the Manhattan side. And they're actually having a discussion about the cholera pandemic of 1873. Again, in the tradition of bringing together basic sciences with clinical medicine. Well, on the next slide, you will see what we have in store for us this afternoon. 2 stellar talks. First of them is a talk entitled Epigenetic Contribution to Systemic Lupus Erythematosus. And our speaker will be Dr. Lindsay Criswell, who is currently the director of the National Institute of Arthritis and Musculoskeletal and Skin Diseases. And she has a research lab in the Genome Institute in the Genomics of Autoimmune Rheumatic Diseases section of the Genome Institute. Before she came to the NIH, she was the vice chancellor of research at UCSF Medical School. She got her medical degree at UCSF, her MPH at Berkeley, and a Doctor of Sciences degree in genetic epidemiology at the Netherlands Institute for Health Sciences in Rotterdam. A few years ago, she was the Henry Kunkel Young Investigator Award winner, and more recently was inducted into the Association of American Physicians. Her research work concentrates on genome-wide association studies of lupus, rheumatoid arthritis, and Sjogren's syndrome, epigenetic signatures of inflammation and autoimmune disease, and health disparities in the autoimmune diseases. And as a special treat today, Dr. Criswell is going to be interviewing a patient during her presentation. My colleague got a little bit ahead of things there when I clapped my hands, but now I'll clap my hands. And now we should go ahead to the second talk, which is entitled Anti-cytokine Autoantibodies, Important Underappreciated Cofactors in Rare and Common Conditions. And our speaker will be the incomparable Dr. Steve Holland, who is an NIH Distinguished Investigator, Director of the Division of Intramural Research at the National Institute of Allergy and Infectious Diseases, and he has a lab there in the NIAID as well. He's the Emeritus Deputy Director for Intramural Clinical Research, got his medical degree, Infectious Diseases Fellowship at Johns Hopkins, and he's a member of the National Academy of Medicine. His research interest is in the genetic susceptibility to primary immunodeficiency disease, mechanisms of bacterial pathogenesis, and cytokines and their receptors in the pathogenesis and therapy of infections. Well, without further ado, we need to get on with it because we have a spectacular session in store for us. And I would just like to have Dr. Criswell take it away. Take it away.
All right. You see my slides?
Indeed.
And you can hear me okay?
Indeed.
Great. So thank you so much, Dan, for that introduction. And my thanks to Wynn for the invitation to present as part of this series. It's a great honor and privilege. And I have no disclosures to report. So I'm going to begin this afternoon with a very brief overview of lupus. And then as you heard, we have a wonderful opportunity to interview a woman, Jennifer, who has experienced life with lupus for many, many years. I first met Jennifer when she volunteered for one of my research projects, and I know you'll really enjoy hearing her story. After the interview with Jennifer, I'll share with you some of the progress related to defining the genetic contribution to the disease, including how it's helped us understand etiologic pathways that operate in lupus. And then I'll share with you what we're learning about the epigenetic contribution to the disease. I'll focus on studies involving the epigenetic modification of DNA methylation, in part because of the important link to the environment. So lupus is the prototypic systemic autoimmune disease. It's very striking for the clinical heterogeneity. Like many autoimmune diseases, women are at dramatically increased risk compared to men, with a 10-fold difference in the case of lupus. Ethnic minorities are also at increased risk for disease and for severe disease in lupus, a really striking feature. The disease is associated with very substantial morbidity and mortality. The etiology is complex, but there is a clear-cut genetic contribution, and there is no pathognomonic test for diagnosis, which has been a major challenge, not only for diagnosis, but also for trying to understand the etiologic contributions to the disease. It's a chronic illness with no cure, although there have been some recent progress related to new therapies in lupus, which gives us all hope that we can make substantial progress in this disease. So this slide just illustrates some of the many manifestations of the disease. Especially prominent are, let me get my pointer out here, a variety of skin manifestations in lupus. Shown here is the classic butterfly rash or the malar rash, a discoid rash, which can be quite disfiguring. Photosensitivity can be observed, can be very prominent. Kidney involvement is one of the most serious complications of the disease and can lead to end-stage renal failure, even death. Involvement of the central nervous system is relatively common. Arthritis is also common, but there are many more manifestations not pictured on this slide. Lupus is also striking for the numerous autoantibodies that are present among individuals with the disease, many of which have very specific clinical associations. These include anticardiolipin antibodies with thrombosis, anti-SSA and SSB autoantibodies associated with neonatal heart block and very specific skin manifestations. Anti-double-stranded DNA antibodies are associated with renal disease. There's also increasing evidence that the antibodies may have the strongest associations with specific genetic factors. So now let me turn to Jennifer's story. I'm going to touch upon her experience getting diagnosed with lupus, what it meant as she contemplated considering having children, the many challenges she experienced living with lupus, what it was like to be a lupus patient in the era of COVID, and lastly, the role of research, what that's meant to her over the past couple of decades. So I'm going to stop sharing for a moment, and then Jennifer will join me on the stage, so to speak. So I can see Jennifer. I'm not sure whether the two of us are side by side, but that's the goal here. Here we go. And I'm going to pretend that I'm sitting right next to you, Jennifer. Thank you so much for joining us. I know the audience is going to really appreciate hearing your story. So why don't you begin by telling us your experience getting diagnosed, what your first few symptoms were, what led to the diagnosis, and what you were experiencing at that time.
Well, first, thank you for having me. I'm honored to be able to share my story today. In terms of diagnosis, I was diagnosed just over 30 years ago. So I've lived more than half of my life with lupus. I just finished my second year of undergraduate studies at the time, and really it was around May of that year, two things happened simultaneously. The first thing was I developed a very robust cough and pain in the chest with deep breaths. And that was diagnosed fairly quickly by my primary care provider as whooping cough. So I was given Tylenol with codeine to help me sleep, and that was that. Simultaneously, I'd had a routine physical, and the lab results from that physical kept coming back abnormal. And so I'd go in and give more blood, and they'd run more tests. And I think over the course of several months, I heard initially a false positive for syphilis, which I knew was not the case. Then I heard a connective tissue disorder potentially. I recall hearing potentially a blood cancer. So this series of disturbing results sort of paralleled the track of the really persistent and uncomfortable cough. After about 3 months of this, I received a call from a nurse in the primary care office who said the doctor had read an article, and the doctor suspected that the whooping cough was actually pleurisy, and that the abnormal labs were due to antiphospholipid antibodies. And she told me three things that day. It was the day before my 20th birthday, that I likely had systemic lupus, that I was at very high risk for a stroke, and that it was unlikely I would ever be able to carry a pregnancy because of the clotting risk. My parents paid out of pocket for me to see a rheumatologist so I wouldn't have to wait 3 months until one was available. The rheumatologist confirmed immediately that I had lupus. I wasn't put on any medications at that time, and when I asked what was going to happen to me, I was told, we'll know in a year.
So what a devastating blow at the age of 20, you're in college. I can only imagine, what was going through your head. So I know that you went on to have some other manifestations, that you struggled to kind of find the right treatment and balancing that with side effects. And I think the audience would also be interested in hearing more about how you pursued your desire to have children, and how you got to the point where that became a possibility, and then your experience with your pregnancy.
Yes. Well, during that year, it became clear that I was going to have primarily arthritis in multiple joints. Inflammatory arthritis became my main challenge. Also, photosensitivity, rashes in the sun. I developed a full mylar rash while pregnant, so I've had some skin components. I will say that, you know, being told that I couldn't have children was not something I was willing to accept. And I have to say that because I was involved as a research subject in your research projects, I think I had so much faith in research and potential advancement in our understanding of this disease that I really pushed and was finally connected with a high-risk OB who was willing to take on my case. And I found a teaching hospital. I wanted deliberately to give birth if I could get pregnant at a teaching hospital because of, I believed I could get the latest, you know, most attentive care there. So in 2000, in my very late 20s, when I finally was ready to have children, the plan was I would give myself twice daily injections of Lovenox to sort of prophylactically prevent any kind of clotting. And other risk factors I knew of, I had antibodies that would put the baby at risk for fetal heart block. So they were monitoring for that, obviously trying to hopefully keep my lupus under control. The wild card was when I did get pregnant, it was a spontaneous twin pregnancy. So then multiples came into play. I was fine really until the end of my 33rd week, and I developed suddenly very high blood pressure and noticeable swelling. I was admitted to the hospital, and the high-risk OB, I remember him, my doctor was out of town, his partner was there, and he said, "Where are your liver labs?" He kept asking me over and over again. There weren't any liver labs, but he suspected and confirmed I had HELP syndrome. And so they delivered the babies by emergency C-section at exactly 34 weeks. One was 3 pounds, 12 ounces. The other was 5 pounds, roughly. I remained hospitalized for a week. Developed clots in the C-section. It was left open and packed daily for about 6 weeks to heal. Very, very painful. The babies were in the NICU for about 2 weeks, but we all survived.
Yes, remarkable. And that was the HELP syndrome, which is a form of severe preeclampsia for the audience, a very scary period. So maybe you can share a little bit about lupus as a chronic illness. You ended up having to change health insurance plans over time, and how you struggled with continuity of care. And then maybe you could talk about the new medication that was added, Benlysta, and then what that meant when we entered the era of the pandemic.
Yes. Well, I looking back over 30 years, that two key themes have been fairly consistent in terms of the workload associated with managing lupus. It's a significant amount of work to manage a chronic illness, and in particular one in which not all doctors are very well versed. That puts a lot of responsibility back on the patient. Certainly challenges care continuity, any life change in the United States, because we have a fragmented health system, often necessitates a change in insurance and then a change in providers. And even if all your providers use the same electronic health record, it doesn't ensure continuity of trend lines. Those, even though they're available, appointments are short and it's not readily available to providers. So I find a lot of responsibility for care continuity falls on the patient. Sometimes I miss the days of hand carrying records between providers, because that was a little more, seemed more reliable oftentimes. And then the other thing that has been a real theme is really medications for lupus, in terms of we haven't had a lot of new medications until fairly recently. And it's not unusual to have medications that have side effects that don't work for you, so you have to discontinue those, or medications that maybe work well for you but get pulled off the market or get a black box warning because suddenly they're known to cause clotting risk. Some meds are not advised to be taken long term, like prednisone. I'm very fortunate in that I was able to start taking Benlysta infusions. I think that's a monoclonal antibody. I started that in 2019. And, but again, going back to the work, it takes time out of your day to go get an infusion, sit there for a couple hours. And also those medications are very expensive. And that puts a lot of work then on the patient to try to figure out how to pay for it, how to access patient assistance programs, and, and to weigh risk benefits. Is PML, getting the risk of getting PML, something you're willing to trade off in exchange for maybe having your disease under control. So again, it's a lifetime's worth of work when you get one of these diagnoses.
And then you were on Benlysta, that helped with some of your symptoms, but that also created more immunosuppression. And now we enter the COVID era. So how did that affect your decision-making, and how did you meet that challenge?
Well, I think everyone had a certain baseline of concern and worry during the pandemic. And for someone who's immunosuppressed, there's an added layer on that cake. And, when vaccines became available, I was chomping at the bit to get one, but I knew I would need to do that research on my own. So much of chronic illness is managed outside of a clinical encounter. There's months that go by where you need to be educating yourself. So I did a lot of work to make sure that an mRNA vaccine was safe, and of course then self-advocating to get a booster when those became available. Not all immunosuppressed people fall into the same bucket. And so understanding those gradations, navigating that. And just this last week, the CDC came out and recommended potentially a fourth shot. So, the list of work and tasks goes on.
Yeah, great. So lastly, Jennifer, maybe you can say just a word about what participating and contributing to research has meant for me. I want to say that I was just thrilled to have the opportunity to recruit you to our research team early on. You contributed so much because of your perspective as a patient who is experiencing this illness. And I just have really valued our relationship over many of those years. And so maybe you could share a little bit of that with the audience. And then I think we'll have time for some questions that before we move on after that. So.
Thank you. Well, as you know, I stumbled upon your research studies 23 years ago and enrolled, and it changed my life. Personally, when you get a diagnosis like of systemic lupus and are told no children and are told, that you'll have to just live with a high risk of stroke, it takes away a lot of hope. And I found that taking part in research as a patient restored my hope that things would improve. And it also gave me a sense of control that even if we didn't have a cure, I could help move the ball downfield in terms of getting closer. Professionally, as a communications professional, I changed my career 23 years ago to focus exclusively on making research more understandable, more accessible to people. And I've spent the last 23 years doing just that. So it's something I remain committed to. It is not lost on me that my twin daughters are now the same age, 20, that I was when I was diagnosed. I know there's a genetic component, and I know we still don't have a cure. That said, I know we have new medications coming out, research continues, and my hope is that, as much as COVID involves the immune system, maybe by chance this pandemic will lead to additional understanding of the role the immune system plays in illness. So I remain very optimistic and as committed as ever to research.
Great. Well, thank you so much for sharing your story. And I'm going to turn things over to Dan now, I think, in case some questions have come up that maybe you can address at this time.
Yes, thank you very much, both Jennifer and Lindsay, for this wonderful interview. For the questions, anyone who in the audience who has a question for Jennifer, you just have to submit the question to the send live feedback option in the videocast display, and my colleague, Kenny, will forward those questions to me. Right now, I don't see any in the chat at the moment, but Jennifer, maybe I can ask a couple of questions while we're waiting for some to come in. So that was really a very, very moving and riveting account of what happened. Can you tell us a little bit more about, over the course of your illness, what about lupus has had the biggest impact on your life?
I think the fact that lupus has so many different, it's characterized by flare and remission, and stress can cause the disease to flare. Who among us doesn't experience stress? And so I think aside from dealing with some of the physical challenges around arthritis, pain, which can be significant and get in the way of sort of activities of daily living, the fact that one needs to constantly monitor exposures to sun. I live in California, that can be a challenge, stress, but how do you balance that with living a full life? How do you balance that with knowing that you know, you could have a stroke? You just have to integrate it into your life. It's like an unwanted guest that moves in, and you just need to learn to accommodate it. So I will say mentally, it can take a toll on your mental health. And I had, particularly early on, I struggled with depression, trying to figure out how to lead the life I wanted to while having this disease.
Yes, I can imagine. And at least from my recollection, you said that you were diagnosed at the end of your second year of college. So there were probably significant stresses just in terms of exams and various deadlines that you had as part of college. And I can just imagine that psychologically, if you start to think that the stress is going to induce a flare-up, then you get stressed worrying about the stress.
You're spot on. It's a vicious cycle.
Yeah. Well, while we were talking, someone has sent us a question, and it is, how important is it to Jennifer that research be honest with its subjects? In other words, giving you some feedback in terms of the results and what they mean, whether they be promising or not promising.
It's absolutely essential, and I want to acknowledge something that Dr. Criswell said, which is that she saw it as a priority to involve patients in research. And I think when patients are seen as co-partners in research, I know Pecori does a great job of the co-design model. Transparency is essential. Patients are capable. They're the ones living with the disease. They can handle that news. And I think being honest, but having an evolving relationship with a patient during the study, not just recruitment, but focusing on retention and information, having that open, transparent dialogue is essential.
Yes, I certainly agree with that. How about patient advocacy groups? Have you been involved in them? It sounds like probably you have. And what is the role of that in the whole process of living with a chronic disease?
I was heavily involved in patient advocacy groups, particularly when I was working on Dr. Criswell's studies, because they can be such a rich source of recruitment for research. I can tell you I subscribe to many different Lupus Foundation of America, the Autoimmune Disease Society. newsletters just to stay informed. I referenced the fact that a lot of the work falls on patients. So one thing I'll stress is these advocacy groups do a great job of communicating in plain language, and that is the emphasis of my professional life, but it is absolutely essential to help people be engaged, because if you can't understand, you cannot be engaged.
Yes. And a lot of times the medical jargon can, even if the physicians think that they're speaking in plain language, it may be plain to them, but not to anybody else. That's for sure. Well, we have another question that's just come in. Can you speak to some of the biggest communications issues between patients with lupus and physicians?
Jargon. And I will say this, the number one piece of advice that I can give and have given over the years as a patient advocate is to not be afraid or ashamed to say, I don't understand. Can you say that again in plain language? It is absolutely essential if you want a patient to be able to leave your office and I hate using the word adhere, but take the medication you've prescribed, go get the test done. There has to be understanding, there has to be buy-in. So from a patient standpoint, if you don't have a provider who's skilled at plain language, don't be afraid to ask for that. And also employing teach back, saying as a patient, here's what I heard you say. Is this correct? Is this what I need to do? And providers should be doing that as well.
Mm-hmm. Yes, I think those are very wise pieces of advice. So we have now a couple more questions, and then I think that we'll move things back to Dr. Criswell, and there'll be opportunity at the end for people to ask questions as well. But question number 3 is, what has been the most valuable strategy in managing the idea that you cannot escape something that is inherent in your own body? Have you found meditation, therapy, or something else helpful?
We have too much stigma in this country around mental health, so I never hesitate to share that I sought therapy to help me learn coping mechanisms, to learn to be at peace with it. You can't fight something that's in your body and avoid being stressed and driven to the brink. So I had to learn to coexist and maybe develop a more respectful relationship with the disease. Has certain needs. Sometimes I have to pause and tend to the disease's needs, but it doesn't mean that those needs are paramount and override what I want to do. So it's a little bit of a trade-off, but I can tell you 30 years in, it is an ongoing process and can still be a struggle.
Yeah, that's for sure. Okay, well, I'll just ask the last of the questions now that's come in. Given that electronic records are commonly available, what do you see as the impediment to their uniform adoption and the need for the patient to shoulder the responsibility to transfer their own records? But why can't we just have a good electronic medical record system that is universally applied?
Such a simple concept. We hear the term interoperability thrown out a lot, and occasionally you hear people saying we're there already. And I'm going to use an example. I'm going to name a name here, and that's Epic. For example, many of the health systems are on Epic. In the course of 4 years, I was at 3 different health systems, all used Epic, and my records were never fully integrated because it is at the health system level, this hesitancy to pull in all of that data from health system A when you're at health system B. And I understand it's technically possible, but should a provider be spending their precious time doing that? Should it be at the system level? We need systems to really commit to making that easier so that at the point of care, that information is present so doctor and patient can make the best shared decisions, during the limited time they have together.
Yeah, making the best use of their time, because if you spend all your time fumbling around trying to figure out what the record shows, and then it's time to move on, that's not a good situation at all. All right, well, that's it for the questions that we have. Jennifer, thank you so much. We all really appreciate your being here, and it's just such a important thing, especially when we're talking about human illness, to actually have to put a face on it. So thank you so much.
Thank you.
All right, can you see my slides again, everybody?
Yes.
And hear me okay? So thanks again, Jennifer, that was wonderful. So as I mentioned, there's no pathognomonic test for lupus. And what physicians face when trying to determine whether individuals have lupus is they consider a long list of manifestations, classification criteria. And in the case of lupus, although these have been revised recently, the way to determine whether someone meets criteria for lupus is to consider these 11 criteria and then ask the question, okay, well, have at least 4 of these been present? And if so, yes, this person can be classified as lupus, and if not, then no. But, you know, it's easy to understand the great heterogeneity of the disease with such wide-ranging manifestations. Now, I highlighted in bold the manifestations that Jennifer had. So she met 7 out of these 11, but has not had any evidence of renal involvement over 30 years, for example, and hasn't experienced some of the other manifestations. So tremendous heterogeneity and challenges for diagnosis. Now, she also had low levels of complement, a common manifestation, not part of the criteria, but that likely was related to the very serious pregnancy complication that she had, the HELP syndrome. So a really complicated disease. So now, what about genetic factors? Some of the earliest insight to the importance of genetics came from twin studies. Pictured here are 2 sets of identical twin girls. They're actually very healthy. They happen to be Jennifer's twins in the middle and my twins on the outside. We had twins about 4 months apart. And it's studies of concordance for disease in twins that gives us some insight into the strength of the genetic contribution to lupus. Now, for lupus, like many complex diseases, the concordance for the disease among identical twins is only about 20 or 25%. So much of the disease risk relates to factors other than genetics. The concordance among fraternal twins is much less, 2 to 7%. The concordance among siblings of an affected individual, even smaller. Now, in spite of the fact that genetics had a clear-cut role, it was painstakingly slow to try to identify genetic factors until it became possible to perform genome-wide association studies, when we could look at large numbers of variants in well-characterized sets of cases and controls. And following that capability, there's been just an explosion of the identification of genes for lupus and other autoimmune diseases. This is a snapshot from a few years ago to show you how rapidly progress occurred. This is a meta-analysis of almost 6,000 lupus patients, over 13,000 controls, all of European ancestry in this case, identifying 63 risk signals. And just to orient you to this Manhattan plot, every dot on this slide is a genetic variant. The strength of association with the disease is shown on the y-axis, the minus log p-value. Huge MHC contribution, but contributions from many, many other genes. Some really striking findings from the emerging GWAS studies in lupus and other diseases was, not only how it was possible to identify a large number of genes in a single experiment. All of these loci were identified just in the context of that single study, but many of them, more than half, were being identified in the context of GWAS studies of other autoimmune diseases, even autoimmune diseases with very different clinical manifestations. So a lot of shared risk across very heterogeneous sets of diseases. Another very striking finding was the extent to which genes related to the toll-like receptor interferon type 1 signaling pathway, simplified and illustrated here in a simple way on the slide, were being identified in genetic studies. Virtually every gene represented here has been demonstrated to be associated with lupus. Now, I'm going to highlight, I'll point out just a couple because they have been very prominent in genetic studies of lupus, including STAT4 over here and IRF5. But virtually all of these genes have been associated with the genetic contribution to lupus. Now, I've been talking about the heterogeneity of the disease. STAT4, one of the very first genes to be identified in the last decade or so, provided us with great insight into the extent to which genetic associations would vary according to specific manifestations present. We had the opportunity to look at the STAT4 risk variant, which was first identified for rheumatoid arthritis. We said, gee, is it associated with lupus? If so, perhaps especially among patients with arthritis. Well, in fact, there was no association with arthritis and lupus for STAT4, but a very strong association, large, high odds ratios among individuals with renal disease and early age of onset. So that gave us insight into the extent to which genes would influence the specific manifestations present. So we, over the ensuing years, were able to reanalyze GWAD data broken down into subsets of diseases to try to understand the genetic differences. What I've shown here are two Manhattan plots now from 3 studies where we're looking just at double-stranded DNA positive patients here and only at double-stranded DNA negative patients here. And you can see the striking differences in the genetic contribution to these diseases. Huge MHC contributions from STAT4, IRF5, ITGAM, very modest association with double-stranded DNA negative disease. We also looked at renal disease. Here, what we're asking is, once you have lupus, what are the genes that are going to influence whether or not you develop significant renal involvement, a really feared manifestation? What was surprising here was the extent to which the genes that contribute to development of nephritis are distinct from those that influence your overall risk of lupus. Notice the very modest HLA contribution and many other genes that weren't on our radar screen from the case control studies. It also became possible to ask, what is the influence of the number of risk variants an individual has inherited? When we looked at individuals according to the number of established risk variants, and we asked, what were their disease characteristics? It was striking the extent to which certain disease manifestations, such as double-stranded DNA antibodies, other immunologic manifestations, renal disease to a certain extent, were increased among those with a high genetic burden, a large number of risk variants, whereas other manifestations were not increased significantly among individuals with a large genetic risk score. So we know genetics is not the entire answer. There's been a long history of studies of environmental factors that contribute to the disease, but research in that area is very challenging. That in part has prompted interest in looking at epigenetic genetic factors. These are factors that influence gene expression, but don't involve modifications to the DNA nucleotide sequence. I'm going to focus on DNA methylation because of its link to the environment. But the hope here is that epigenetic factors help to explain not only this missing heritability, not defined by genetic risk variants, but also help to fill out the totality of the contribution to the disease. And this is consistent with a long-standing model in which genetic predisposition over time eventually leads to clinical disease in the context of the appropriate environmental factors, perhaps mediated by epigenetic modification. So why look at DNA methylation? Well, it has profound influences on gene expression, and it's both inherited and also affected by the environment. DNA methylation occurs at these so-called CPG sites, where you have a cytosine followed by a guanine, and the degree of methylation influences levels of gene expression. Now, back to twins again, the very first methylation study in lupus was a small study comparing discordant identical twins, 5 sets of identical twins, discordant for the disease, and a set of 5 matched control individuals. What the investigators did here a decade ago now is they looked at 800 methylation sites across the genome, and they compared levels of DNA methylation status between the two twins, with and without lupus, and the healthy controls. Overall, the lupus twins had much lower levels of DNA methylation globally, and especially differentially methylated regions of about 50 genes, many of which have roles in the immune system. So research in this area progressed rapidly, looking at greater and greater number of CpG sites, 28,000 methylation sites in this study, larger sets of individuals with a similar pattern. Significantly differentially methylated gene regions between lupus and control individuals, often highlighting genes relevant to the immune system and inflammatory pathways. Now, the biggest of these so-called EWAS studies, Epigenome-wide Association study, was a Swedish study looking at 450,000 CpG sites, large number of cases and controls, 7,200 differentially methylated sites, many in the type 1 interferon genes, and many influenced by genetic variation in the regions of the CpG sites. And some of those genes corresponded to established SLE risk loci. Now, what about DNA methylation and disease manifestations? I shared some work in the genetic studies showing how different the genetic contribution is according to the clinical manifestations. What about DNA methylation patterns? We've now had the opportunity to perform epigenome-wide association studies in well-characterized individuals with lupus so that we can ask whether patterns of DNA methylation are different. For example, between individuals with double-stranded DNA antibody positive disease and double-stranded DNA antibody negative disease. This slide summarizes results for over 300 such individuals. What's been striking to us is not only the number of statistically significant methylation differences between these subsets of the disease, but the number that highlight gene regions that were not on our radar screen from genetic studies, also prominence of type 1 interferon genes, and the modest contribution of the MHC region compared to genetic studies. So we've looked at autoantibody profiles. We've looked at renal disease, once again, a very important disease manifestation. We see almost 20 significantly differentially methylated regions that distinguish patients who do and don't develop renal disease. In this case, the gene regions that are differentially methylated highlight pathways related to tissue hypoxia and type 1 interferon responses. So as you can imagine, to continue work in this area, it's critically important to have access to deeply phenotyped individuals with access to biospecimens. We've been very fortunate to utilize a deeply phenotyped multi-ethnic cohort that was developed thanks to funding from the Centers for Disease Control and Prevention and led by my colleagues at UCSF. And we have been characterizing these individuals for genome-wide genetics, epigenetics, and other omics to help us better understand heterogeneity of the disease, including greater insight into the race and ethnic differences in the disease. So I'll very briefly summarize some of our work related to the CLUES cohort. So we decided, instead of looking at individual disease manifestations, we know that many of these manifestations are correlated with each other. They cluster together. So we considered all of the ACR criteria and the sub-criteria that had been characterized for these individuals, and we asked whether there were natural clusters of individuals based on patterns of these manifestations. And indeed, 3 clusters emerged from the data, which we have labeled mild, because of the absence of significant internal organ involvement, and then 2 severe clusters that are primarily differ in terms of hematologic manifestations. So both of these groups have significant renal involvement, but they differ in terms of the hematologic manifestations. So 3 clusters of individuals based on the pattern of these many manifestations. So then we asked the question, well, do these clusters differ in terms of their methylation patterns? looking genome-wide and accounting for other factors that would influence methylation status, age, smoking status, cell composition, etc., we found over 250 differentially methylated CpGs that distinguished these clusters. Once again, many of which mapped to the type 1 interferon pathway. Fortunately, we had access to an independent cohort that allowed us to confirm these associations between DNA methylation status and clinical clusters. Now, we can also leverage this data by mapping those 256 sites to genes and then performing pathway analysis. That sort of analysis demonstrates significant enrichment of genes associated with interferon type 1 signaling, antiviral responses, and numerous inflammatory pathways. Now, once again, as I've highlighted, many of the gene regions highlighted in methylation studies are distinct from those that we see in genetic association studies, giving us another perspective on contributions to the disease. So now, once again, I've been focusing on DNA methylation as an important clue to the environmental contribution to the disease. Why is that? Well, patterns of DNA methylation are generally stable, but they can be interrupted. For example, as a result of oxidative stress or other environmental exposures. And there's a long history of environmental triggers for lupus, but it's very difficult in the context of these epidemiologic and observational studies to really demonstrate causation, not to mention to understand underlying mechanisms. So there's great hope that epigenetic change will explain some of these environmental associations with the disease, and that further analysis of epigenetic patterns will provide greater insight into other environmental contributions to the disease. And in fact, there's a lot of interest in this area, and a number of exposures that have been implicated in studies of lupus have now been shown to be associated with DNA methylation changes, providing promise that this is going to be an informative area of future research. I would draw your attention to this really nice review of this subject recently by Christina Lanata and colleagues. So now, lastly, I've alluded to the fact that it's challenging to understand the environmental contribution to the disease. But there's renewed interest in this concept of the exposome that's meant to reflect the totality of exposures across the life course, including all sorts of external and internal exposures. The hope is that by characterizing the exposome in health and disease, we can have a more comprehensive and accurate way of understanding how the environment contributes to the disease, including the relationship to epigenetic factors. So we're really excited about the fact that there are now non-targeted approaches to very comprehensively characterize the exposome in lupus and other autoimmune diseases. And we're excited to see how those studies, what they tell us about the disease, lupus. So let me just conclude my comments by thanking my many colleagues, especially Joanne, Lisa, Christina, Sharon, and Kim, who contributed very importantly to the studies I mentioned, my long list of other collaborators from around the world, our many sponsors of our studies, including the NIH, NIAMS, and many nonprofit organizations, and perhaps most importantly, the many patients with lupus and their family members who have contributed so significantly to our research and provided such great inspiration. And once again, thanks to Jennifer for sharing her story here today.
Well, thank you so much, Dr. Criswell, for that fantastic presentation. And again, thank you, Jennifer, for being willing to tell us a little bit about what it's like to have lupus. So at this point, we'll turn things over to our second speaker, Dr. Holland. Steve, take it away.
All right. Well, thank you very much, Dan and Lindsay and Jennifer. That was really an extraordinary story, both from the patient standpoint and from the scientific one. And I hope that the story I'm going to share with you today is a little bit complementary to that, and that I'm looking forward to getting feedback. So I want to talk a little bit about anti-cytokine autoantibodies. And let me just remind you at the beginning, cytokines, those are how cells talk to each other. You know, we use direct messaging, text, but cells like to send out proteins that go from one to the other and bind to receptors, and then they tell that cell what to do. And that's what we're going to focus on today. I have no disclosures, and my objective is just that you come away appreciating that this is really nifty. So let's just start out, though, with just trying to put us in context. So this graph looks at it's a graph of human population. And you might be wondering, well, Steve, how do you know what population looked like back in, some of these earlier periods and, back in here? And frankly, it's because I asked Dan, and he was able to give me some direct insight. But now the question here is, what is the role of antibiotics? That is, we think, I'm an infectious disease guy, we think antibiotics are important. When were they given? Now, if I had you guys in front of me, I would ask you, which is the first antibiotic? And the vast majority of you who have been marketed mercilessly would say, oh, it's penicillin. No, it is not penicillin. The very first antibiotic in a centennial that went without appropriate herald was really made in 1909. And it was called Salvarsan. It was developed for the treatment of, African sleeping sickness. Unfortunately, it really was not very active against that, and it wound up being used against another sleeping sickness known as syphilis. But it took 33 years from the development of Salvarsan to the development of penicillin. And along the way were the sulfa drugs. And I just want to emphasize that despite the fact that antibiotic development has only been around for 100 years, our species has been growing in number. And I think that tells you that we are actually built to go the distance. And so when we don't, we want to wonder why. For those of you that are interested, I get nothing for telling you, but this is a fantastic book, The Demon Under the Microscope, and I can't say enough good things about it, about the development of antibiotics and how extraordinary it was. But look, the real question here, the elephant in the room, if you will, is why do people get sick? That's really what we want to know. Whether we're doctors, patients, or investors, we want to know, why are people getting sick? Because we weren't built in order to get sick. And so the lens that I use for this are called primary immune deficiencies. Now, what are those? So they go by several different names, of course, just to keep everybody guessing. Inborn errors of immunity, that is, how do we protect ourselves from infection, sometimes referred to as congenital immunodeficiencies. But the point here is that these are immunodeficiencies that are not due to therapy for lupus or therapy for cancer. They're not due to HIV. They're not due to having gotten a transplant. These are things that you were born with. And the study of these over the last several decades has really exploded. And you can see here the rate of the increase of the number of recognized primary immune deficiencies. And you see that the rate has gone up really dramatically. Well, why is that? Well, partly because we know a lot more. You're here, you're paying attention, or maybe, but there's also better sequencing, and the ability to sequence the DNA, it has really transformed how we think about disease. Lindsay just told you about not only sequencing DNA, but looking then at what binds to the DNA. And these are extraordinary opportunities. And then we're doing much better at treating patients. They survive. We have a chance to figure out problems. And then we have a chance to disseminate that information. I want to point this out because it's really changed the world. And that is, when we look here at the prevalence of primary immune deficiencies worldwide, what you see is that the rate of primary immune deficiencies in the United States is somewhere between 5 and 10 per 100,000. Now, that may seem like a big number or a small number, depending on who you are and where you come from. But I want to contrast it to the current rate of Mycobacterium tuberculosis infection, TB, the greatest killer potentially of all time. And now immune deficiencies are 2 to 3 times more common in this country than tuberculosis. And if you're a doctor, think about the last time you screened for TB versus the last time you screened for an immune deficiency. And the fact that the rates are high in the United States, it's not because our genetics are that different than most other places. This is because we're looking and other places have not gotten around to it yet. But this is what we ought to consider the rate is, and it's going to be going higher as we do more DNA sequencing. All right, so that's the background that I want to start with. And why am I telling you this? Because my patient is this woman who came here, was referred to the NIH because she was just desperately ill. She was at that point a 60-year-old who had grown up in Vietnam, had survived the war, had come out on the boats, had lived through refugee camps, had come to the United States where she established a business and a family and was doing great until she got into her late 50s and then started to really lose weight, had fevers, eventually went to her doctor. And what you see here are these spots on her chest. And those spots are teeming with mycobacteria. I'll tell you about that in a second. And they're teeming with mycobacteria because she has these infections in her bone that are not only destroying the bone, but they're then driving themselves out through the skin. And people said, wow, this is bad, and we don't know why. And when we met her, we said, this is bad, we don't know why. So what are these mycobacteria? So it was almost 140 years ago that Robert Koch invited his friends into his kitchen to show them under the microscope. He invited them over for dinner, show them under the microscope the organism that he thought caused tuberculosis. Well, of course, all of his friends said, are you crazy? And that's why he had to come up with these things that eventually got called Koch's postulates. How do you prove that what you think is true is really true? More important than that, everybody said, no way we're having dinner at Bob's ever again. Well, over the 140 years since he discovered that, we're still having trouble understanding why people get tuberculosis. This is what it looks like under the microscope. And this characteristic sort of red appearing bacteria is really what we're after. Well, it turns out that M. tuberculosis is at the very top of that pyramid of pathogenesis or virulence. It's a really nasty bug, which is why everybody knows about it. And then there are hundreds more mycobacteria. And you see here, I have made a fanciful pyramid of the non-tuberculous mycobacteria. Brilliant name, right? It's not tuberculosis, therefore it's a non-tuberculous mycobacterium. I can't tell you where these names come from. But the non-tuberculous mycobacteria, for the most part, do not cause severe disease. In fact, they only cause severe disease in people who have major susceptibility factors, those inborn errors of immunity. And so what do we know about these? So what we know is that the ability of cells to control mycobacteria, and just to remind you, almost all of these organisms here are out in the environment. M. tuberculosis, that gets spread mostly human to human. These organisms are in the environment, and you, I, everybody gets exposed to them all the time. So if you're exposed all the time, you better have a system in place that controls them. And the good news is you do. Here's how it works. This is called a macrophage, this large cell, macro, big, phage, eater, the big eating cell that gobbles up these mycobacteria. And what happens? After the mycobacteria are ingested, the cell makes interleukin 12, which binds up to its receptor on T cells and NK cells. And that leads to the production of interferon gamma, which then works on its receptor on all nucleated cells in the body. And when it binds its receptor, it does a variety of things. It increases tumor necrosis factor, which is a cytokine that makes for fever and weight loss. And it also signals then through other molecules to lead to the killing of mycobacteria inside the cell. And 140 years after Robert Koch has identified this, we still don't know exactly how the mycobacteria are killed. We just know that if you can't do the interferon signal, you're in trouble. And how do we know that? Because mutations in any of these genes and some more lead to severe disseminated mycobacterial disease. Therefore, it's one major pathway that drives from ingestion of mycobacteria to production of IL-12 to production of interferon to signaling through the interferon receptor to killing. And interferon drives forward the production of IL-12 some more. So it's a neat system that interoperates through the production of cytokines and their sensing by receptors to lead to the killing and control of mycobacteria. Now, of course, that's the simplified story, but that's not the whole story. And it turns out that this vacuole, this container inside the macrophage, isn't just designed for the control of mycobacteria. Lots of things live in there. Fungi, bacteria. So here they are. Here are the non-tuberculous mycobacteria, including the M. avium complex that my patient had. But there are other mycobacteria here, MTB and this other one called BCG, as well as other bacteria and some fungi and some viruses. So this pathway turns out to be really important for how we interact with things in the environment. Now, this turns out to be a pathway that when there are mutations in it, mostly shows up in childhood because, frankly, children get exposed to stuff early on. And if you've got a major breach in host defense, then you get sick when you encounter it. So most of these defects start early. So now let's go back to our patient, because no matter how you slice it, I mean, for real, 60 ain't young. And she was fine until she got to that level. So if most of those genetic defects start in childhood and she's getting sick in adulthood, what's the problem? So when she came here to the NIH, we sat down and scratched our heads and said, well, does she have a problem in any of these genes that we've identified before? No. So our problem was that what she had looked like a genetic disease. It acted like a genetic disease. No matter how much drug they gave her, they couldn't get her infection under control. But it's coming on late in life. And when we took the cells out of her blood and we asked them to do acrobatics in the lab, they were fine. So what really could be going on here? And to cut to the punchline, what she has is an anti-cytokine autoantibody. This one actually directed against interferon gamma itself. And this antibody is binding interferon, completely blocking its ability to interact with its receptor, and therefore mimicking completely the condition of having a mutation in the interferon gamma receptor. So as we started investigating this condition, we realized that it was being identified. So she was from Vietnam. Here is a report of a 25-year-old woman from Thailand who was living in Germany, who got another mycobacterium and then another bacteria and died. 25-year-old woman, previously healthy. Another report of a 57-year-old man who had tuberculosis and then another non-tuberculous organism, as well as some autoimmune problems, and he died, previously healthy man. And then along the way, we were collecting patients who had exactly the same problem. And what we found were 6 women, all from Southeast Asia, including the patient I showed you, who had disseminated mycobacterial disease, all of which were extremely severe. And so as we sorted through all this, we said, well, wait a minute. These people all have anti-interferon gamma autoantibodies, but they're all Southeast Asians outside of Southeast Asia. And the antibody there is what's called IgG, the most common of the antibody classes that can bind to these things. And they had a variety of problems like the ones I've shown you. They had lots of infections. We refer to opportunistic infections as the infections you're not supposed to get unless you're pretty sick. That is, things from the environment aren't usually supposed to be causing you disease. So they were severe, disseminated, and fatal. And so we began to wonder if these antibodies are associated with disseminated non-tuberculous mycobacterial infections in Southeast Asians outside of Southeast Asia, what's going on in Southeast Asia? And so I was lucky enough to have read an article by a gifted investigator from Thailand, Plongchan Chaktotsat, and she reported 59 patients in Thailand who had all of these opportunistic infections, bacterial, fungal, viral, and mycobacteria, but none of them had HIV. That is, they looked like they had severe HIV disease, but they didn't. And we realized when we put 2 and 2 together that we were probably dealing with the same thing. So working with Sarah Brown, who was then in my lab, and Peter Burbello, a gifted investigator then in the Dental Institute, we put together a trial to go to Thailand and Taiwan to try and figure out what was going on. And I'm just going to identify here for a moment what were the groups of individuals we sought out. We had people who had disseminated non-tuberculous disease, people who had other opportunistic infections, viruses, fungi, other bacteria, other opportunistic infections with or without non-tuberculous disease. And then because this question about, we think that these mycobacteria are all in a spectrum. So what's the relationship between the non-tuberculous mycobacteria and tuberculosis? So we had patients with disseminated tuberculosis and pulmonary tuberculosis, and then people who were donors in a blood bank, who I think for our purposes, we're going to say are normal. And we put together this group of individuals, and then we decided to measure, actually we measured 41 cytokines at the time because Peter had a brilliant assay that he devised that let us do that on tiny volumes of plasma. But here I'm only showing you the results for the antibody against interferon gamma, because that turned out to be the most important of the ones that we identified. And so when we put this group together, disseminated disease versus everything else, what we saw was that the people who had disseminated disease with either non-tuberculous or other opportunistic infections, the vast majority of them had extraordinarily high levels of antibodies against interferon gamma. Fascinatingly, those who had severe tuberculosis, either disseminated or isolated to the lung, they didn't. Shocking, absolutely shocking. And I'll save you any effort now. I don't know why. But I would argue that it's because tuberculosis and these non-tuberculous organisms just aren't the same. But that's what we found, that disseminated disease was highly associated with an antibody against interferon gamma that was mimicking the problems that occur when you mutate the receptors. What did it look like? I mean, these people were really, really sick. You can see this man had 2 infections going on at the same time, a disseminated fungal infection and a disseminated mycobacterial infection. This woman had huge lymph nodes due to salmonella, which is a bacteria. Here you can see this young man had an infection in his bone with cryptococcus, which is a fungus, and this young woman had extensive skin disease. So all of these in people who had high levels of antibody against interferon gamma. So the first point here is that these antibodies that come on late in life mimic genetic disorders. And you can see, I think, exactly why. They take out a critical signal molecule that's in exactly the same pathway as all the other defects that have been identified. So then I think, all of us as sentient humans spend a lot of time saying, why? Why me? Why now? Why this problem? And that was the question that people turned to next. And so why did these people start to get these problems? And why were we finding it so frequently in people that originated in Southeast Asia, but not in the vastly larger number of people in the countries that surrounded them? And so a really gifted group in Taiwan began to look into this, and they focused on the HLA molecules. Now, you may have seen that coming up in Lindsay's data, the highest peak that she had for most of her genome-wide associations was in the MHC complex. And some of those MHC molecules, this is what they do. They come together in a little cluster, and they form a very special pocket. and only, only specific keys can fit into the pocket that they form. And what they identified in patients who had these anti-interferon gamma autoantibodies were two particular molecules that go into making up those pockets of the HLA complex. And that was sort of fascinating in and of itself. And then they went on to say, well, okay, why is that particular set of molecules occurring? Remember, those molecules are making the capacity to bind only certain things. Well, what was the certain thing that they bound? It turns out that that binding pocket made by those molecules corresponds to the last amino acids of the interferon gamma molecule. And even more interestingly, that last part of the interferon gamma molecule here, shown in red, turns out to be identical to another gene that shows up in a fungus called Aspergillus. Well, so here you see in this table, this is the amino acid sequence of interferon gamma. This is the amino acid sequence of this gene called NOC2 in Aspergillus. And so those authors said, well, wait a minute, here's what we think's going on. We think that humans are inhaling or maybe eating Aspergillus, and that their immune system recognizes this protein in Aspergillus called NOC2. You then make an antibody against that protein NOC2, but that antibody against NOC2 cross-reacts against interferon gamma, and now that antibody is blocking the interferon here in the green, and then causing this problem of interferon gamma deficiency due to an antibody. And they showed that this made some sense because they could actually take the molecule of interferon gamma, take out that part that was being recognized by the antibody, and then the interferon worked all over again. So here they've changed it from a diamond to a teardrop. Now, whether this is exactly the exposure that leads to what we call molecular mimicry, I don't know. But it certainly makes sense, and it's clear that just as Lindsay was talking about environmental exposures, this is an environmental exposure that could be driving an immune reaction that then leads to severe disease. Well, why do we care about understanding disease? Well, because that's our job. But because once you understand the disease, you can change its course. And so once we identified that these patients were getting sick because they had autoantibodies against interferon gamma, and we know that antibodies are made by B cells, then we realized that we could go and whack those B cells and make their antibodies go down. And so, in fact, here was the level of antibody before treatment, and here's what happens to antibody during treatment, and then here's what happens after treatment. As further proof that this is really important, this is the patient whose slide I showed you, who had the spots on her chest. When we stopped giving her the drug to take out the B cells, her levels went up. She had a clinical relapse, that is, her infections came back, and we had to give it to her again, and then everything resolved and went away. So this problem, the anti-interferon gamma autoantibodies, are a fascinating example of what we refer to as genetics, gender, and geography. And genetics is obvious because you've got the HLA association. The gender is fascinating because the vast majority of people outside of Southeast Asia who have been identified are women. Whereas in Southeast Asia, the rates between men and women are roughly the same. And geography, because it's only people who are born there in Southeast Asia, for the most part, in whom this happens. People of the same ethnicity born elsewhere don't seem to be as susceptible. It's clearly got genetic components, and I think we can treat it. So that's an example, only one example, of an anti-cytokine autoantibody causing a disease that mimics a Mendelian disease. Now, the next question is, well, okay, that's a rare set of problems. Is this involved in common problems? Does this occur outside of those primary immune deficiency-like diseases? Do these occur in more common diseases? So harking back to what Lindsay was talking about, we worked with Sarthak Gupta and Harry Matsopoulos, Sarthak here at NIAMS and Harry, a rheumatologist in Athens, to say, okay, what about in the autoimmune diseases that we already know a lot about? Are these autoantibodies occurring there? And if so, are they important? So just to remind you that lupus occurs in about 0.1% of the population, but that's a big number when you're talking about 330 million people. Rheumatoid arthritis, about 1%, and Sjogren's up to 3% of the US population. So these are big time diseases. And we performed a similar exploration, trying to identify antibodies against cytokines in patients who had those diseases. So what did we find? And I'm just going to briefly highlight this. We found that actually there were a fair number of antibodies against interferons and other cytokines in this population. So here, the black boxes are the normal range identified through essentially normal volunteers or blood bank controls. And anything outside of those black bars is elevated. And in fact, there were a fair number of antibodies against different interferons, as well as against other cytokines. And then the question was, okay, is that clinically important? And without going into how they make up these scores, there is this opportunity to look at patients with lupus and look at their blood and say, okay, what genes are turned on? And it's in general thought that lupus is a disease of interferon alpha, or type 1 interferon activity, or at least that there is a lot of interferon activity in it. And so we looked for what were the signatures for that. And so it turns out that if you're blocking interferon gamma, the level of interferon alpha signaling goes up. And we've actually seen this in the genetic conditions as well. If you block one, the other one is increased. So it turns out that if you were blocking interferon gamma, your score for interferon alpha activity was higher, suggesting potentially worse lupus. In contrast, there were other people who had autoantibodies against interferon alpha. And if they had autoantibodies that blocked interferon alpha, that actually made their degree of lupus significantly less in terms of the scoring system. So this suggests epigenetic, as it were, modifiers of lupus scores and lupus severity that often don't get taken into account. Okay, so now what about now that we've talked a little bit about rare disease, about more common disease, what about really common disease? What about goes on in pandemic disease? So in this really elegant study done by Gigi Notarangelo, Helen Su, and Jean-Laurent Casanova, they went to northern Italy to obtain samples from people who had severe COVID-19 disease. And this was like, ICU, severe. And in the genetic part of the study, what they found is if you look at only 13 genes around the respiratory system and how the viruses respond, that is, can you sense the virus, can you respond to the virus by making interferons, only about 3.5% of people had mutations in genes around that. That is, they had monogenic problems that predisposed them to getting severe COVID-19 disease because they could either not sense or not respond to infection. Here you see sensing, and here you see the interferon response. And that corresponded to this kind of problem. So if you look at those people who had mutations in those genes that were either viral sensing or response, and then you look at the level of interferon alpha in their blood, what you see is that if you can't sense the virus or you can't make the interferon, then in fact, you've got no interferon alpha or type 1 interferon detectable in your blood. This is what the normal level looks like in people who are getting sick with COVID-19. So that makes good sense. Interferon is important in controlling viruses. These people can't do that, therefore they're getting sick. But it turned out there was another set of people who had severe disease who also didn't have detectable interferon in their peripheral blood. But these people did not have mutations. And oh my gosh, this takes us right back to the beginning, because this looks like a genetic disease. This acts like a genetic disease, but it's coming on late in life. And the in vitro cellular behavior is normal. So what's going on here? Well, you've already guessed it. These people have autoantibodies, now not against interferon gamma, against another interferon called either alpha or omega. And what this is simply showing is that a lot of the people who had life-threatening COVID-19 disease who didn't have mutations had these autoantibodies against interferon alpha or interferon omega. And the rate of those antibodies was much higher in those who had life-threatening disease compared to those who were asymptomatic or healthy controls. And those antibodies really blocked all of the signal. So yes, we had problems in some of the genes in a small number, but almost 3 times as many patients as had genetic problems had acquired problems, these autoantibodies. Now, it's still a little unclear what is cart and what is horse. In studies done here, we know that there is a very dynamic rate to these, and they go up a little bit early in the course of disease, and then over the course of time, these antibodies fall back down to the normal level. So they are dynamic, and so they're going to be changing over the course of disease. Lastly, once you light the fuse, it's hard to know what goes off. And in this very important study from Dr. Criswell's alma mater, if you look at the change in autoantibodies in people who have been infected over the course of their hospitalization, what you see is that being infected with COVID-19 can trigger the development of autoantibodies against a variety of molecules, including interleukins, interferons, and other cytokines. So this is both something that is affected by having autoantibodies and maybe generating autoantibodies. Okay, so I'm done with the expositional part, and I'll just say here that I have mercifully spared you from hearing about anything other than just interferon gamma and the type 1 interferons. But that's not because there's nothing else to say. And there are autoantibodies to a variety of other cytokines, and those are modifying and causing disease that have not yet been sorted out. So these anti-cytokine autoantibodies are acquired innate and adaptive immune defects that are dynamic. They can have on-target and off-target effects, and we can treat them. And I am sure that they cause more disease than we think. So, we started talking about genetics, and then we wound up talking about epigenetics. And so I just want to remind you that there's genotype and then there's phenotype. And genotype mostly stays the same, but phenotype changes with time, exposure, environment, and I dare say, with satisfaction. So I just want to stop and acknowledge my extraordinary colleagues here. Lindsay Rosen, Krista Zerbe, Sarah Brown, and Lee Ding have really been the ones driving our autoantibody work, as well as many collaborators that have been involved, especially for the COVID work with Gigi Notarangelo, Helen Su, and Alana Shah. Our terrific collaborators in the Dental Institute, in Athens, in Thailand, and in the Human Genome Project. And then our collaborators in NIAMS, Dr. Criswell, this is not for your benefit, but I will just say they have been extraordinary collaborators, Dr. Gupta and Hasni and others as well. And so I will stop there, and I look forward to a chance to interact over questions.
Well, thank you so much, Dr. Holland, for that spectacular talk. So at this point, we will gather together our various presenters, Jennifer and Dr. Criswell and Dr. Holland, and Dr. Arias is here on the screen too. And we'll just entertain questions that we have. And actually, we have gotten a bumper crop of questions. I don't even know if we'll be able to get through all of them, but certainly for the ones that we don't get to, we can always address them to the speakers later on and get back with you with the answers. So one question that comes up that really ties together the two talks has to do with the whole issue of type 1 interferons and the fact that type 1 interferons play an important role in autoimmune diseases like lupus, but are also important in terms of resistance to certain bacterial infections. And so the questioner wants to know whether in patients with lupus or perhaps with other autoimmune diseases, are they more resistant to certain viral infections? And this could really be addressed both to Dr. Criswell and to Dr. Holland.
I'll start, and I'm sure Steve may want to add, but the relationship between autoimmunity and infection is fascinating, changes over time. Infectious threats in the environment have probably influenced our genetics in such a way that it's resulted in predisposition to autoimmune diseases. So really complicated relationships between autoimmune diseases and infection. In terms of lupus and viruses, the most notable association is significant evidence that certain virus infections can trigger the onset of lupus. The strongest data is for Epstein-Barr virus, the virus that causes mononucleosis. There are also case reports of other viruses, such as the varicella virus that causes chickenpox and shingles, for example, triggering the onset of lupus. Jennifer didn't mention, but a year or so before she developed lupus, she had chickenpox, and one might wonder whether that might have contributed to triggering her disease. So I'm not aware of substantial evidence that suggested that once someone develops lupus, they're protected from virus infections, but Steve may have another perspective on that question.
Okay, well, let's see what Steve has to say.
Well, I would never disagree with Lindsay, and I don't here. I think the literature about infection susceptibility in a lot of the autoimmune diseases is heavily affected by treatment. So steroids clearly increase the risk of infection. Many of these other drugs increase the risk of infection. One of the fascinating things is that in almost all of the primary immune deficiencies, that is conditions where you've got a lot of infection susceptibility, it's coupled to an increase in the rate of autoimmunity. And exactly why that is, I don't know, but I would certainly defer. I think that lupus per se is not an infection aggregating disease. It may be triggered by an infection, but they don't get more bacterial infections in the absence of therapy that I'm familiar with.
And just following up a little bit on what Lindsay had raised, the question of whether perhaps the selection for responsiveness to certain pathogens might increase the frequency of variants that increase immune responsiveness, interferon production, or whatever. Is there any direct evidence of that, Lindsay, that you know of in terms of studies of genome structure, looking for large haplotypes, let's say, that would be associated with particular variants of interferon-related genes in the general population?
Yeah, I'm afraid I'm not aware of direct evidence, but there are a number of very attractive theories that would connect those two things. And for example, there's a genetic risk variant, a functional variant in PTPN22 associated with many autoimmune diseases and has very striking variation in allele frequency within Europe, for example, with very high frequency at north, low frequency in the south, for example. And an attractive hypothesis is that pattern, the difference in allele frequency, reflects an infectious disease selection pressure, perhaps the plague, that went through Europe and resulted in selection for certain variants that protected against disease that have, as a consequence, now an increased risk of autoimmune diseases. So it's evidence like that I think suggest that hypothesis. I'm not aware of, the sort of evidence that you alluded to, Dan. Once again, perhaps Steve is aware of some evidence on that front.
Okay, well, Steve is shaking his head no, but this is just, I guess, an opportunity for more research that perhaps following up on that PTPN22 variant, perhaps there's something more there that could be found. But it's a very fascinating idea that perhaps that high frequency in Northern European populations is there for a reason of some sort. All right, well, now that I've picked on Doctors Holland and Criswell for a little bit, now it's time to go back to Jennifer. She thought she was off the hook, but that hook is a pretty big one here. And so here is a question from Kathy. And the question is, how much does diet contribute to flare-ups in the body? And what are the foods that you enjoy to alleviate swelling in the body? And I guess that I could add another question to it. I was, trying to think up questions just in case nobody asked any questions. And so, there's the vitamin D deficiency issue, associated with autoimmunity. And would a diet rich in dairy products like ice cream, would that perhaps help with an autoimmune disease?
Well, as somebody who enjoys ice cream but is also lactose intolerant, it's a fascinating question, and I will say that I've had GI challenges as far back as my teenage years. They persist. And for years, my doctors, including my rheumatologist, had suggested a gluten-free diet, potentially. I did go gluten-free, probably well over a decade ago. That did help. I found that going low FODMAP, FODMAPs are sugars that can be hard to digest. They can ferment in the gut. That in combination with being gluten-free has helped tremendously with gut upset. I've not noticed a correlation between that and my arthritis, though, and I would leave it to Doctors Criswell and Holland to maybe comment on that.
Well, before they do, so what are you left to eat if you're avoiding all of these things?
There's plenty left to eat, and fortunately, we're in an age now with these handy apps on our iPhones. When faced with a plate of something delicious, you can type in that food and see how uncomfortable your next 24 hours will be should you partake.
Hopefully, the app on your phone allows you to eat something, though.
Yes, no, I'm certainly don't go without. I'll say that.
All right. Well, let's see if Dr. Criswell or Dr. Holland have anything to add to those comments.
Yeah, studies of diet and autoimmune disease risk and severity are challenging for a number of reasons, study design issues, et cetera. I've been interested to see some impressive data in terms of the quality of the study coming out of the osteoarthritis literature, implicating certain diets. They characterize diets in terms of Western diet versus prudent diet, for example, being more like the Mediterranean diet. And over years of observation with imaging studies, et cetera, osteoarthritis progressed more rapidly among individuals who were consuming a high Western diet compared to those with a prudent diet. And I was impressed that was not fully explained, only partially explained by weight and BMI. So I think there is still a lot to learn in terms of diet and arthritis and other manifestations of lupus.
All right, well, that's very interesting. I'll have to learn about this prudent diet at some point. Dr. Holland, do you have anything to add to that?
Well, as long as there's coffee in the diet, I don't really care. So I think, what we've, I don't know anything about the specifics of the different diets, but the work being done over the last decade or so in microbiome has really shown a profound effect of diet on microbes and microbes on immunity. Everything from, immune reactivity to cancer. And I think it's really hard to sort those two apart. And certainly I look forward to it being worked out more clearly. But I think we should be humble about the fact that what we consume clearly activates our components, whether it's about lactose or lactase or different bacteria. And those are complicated studies to do because there's so much bacteria in the environment and so on, but they're critically important studies to do. And I think our institute and many others are really committed to trying to dissect out those relationships.
Steve, I'm so glad you mentioned the microbiome, and it reminds me also there's some interesting work, for example, related to the treatment of rheumatoid arthritis and methotrexate as a drug, where the microbiome influences metabolism of the drugs too. So then that's another complicating factor. So I agree that's a really rich area for future research.
Yeah. I mean, like so many things, it's something that we took largely for granted. We assumed that you were passing that stuff out. It wasn't our problem. Well, we're wrong. So it'll keep us busy for quite a while.
Yes, indeed, indeed. So here's a question for Dr. Criswell, sort of hearkening back to her talk. Are twins, which both have lupus, more prone to have the same clinical manifestations than random lupus patients?
Yeah, that's an interesting question. As you can imagine, there aren't a lot of large twin studies in lupus, but small studies that exist suggest that there is not a lot of concordance in terms of the specific disease manifestations among lupus twins. So, you might expect that, the disease features would be very, very similar, but they aren't as similar as one might expect, which once again points to epigenetic factors. And of course, epigenetic differences between twins will increase over the course of their lifetime with time, or differences in exposures, chance events, that probably plays an important role too. So it was an interesting question. Thanks for posing that.
Yeah, and you mentioned the question of epigenetic exposures. I know that cigarette smoking has been implicated, at least in some autoimmune diseases. With the decrease in cigarette smoking in the general population, has there been any change in frequency of autoimmune disease, at least as of yet?
I think one of the strongest associations for smoking and autoimmune disease is probably rheumatoid arthritis, where the lung and exposures through the lung, including cigarette smoke, are really important in terms of, triggering the disease and contributing to disease manifestations. And that probably explains some of the variation in risk around the world. But there's so much else that contributes to the disease. I think it's hard to definitively say. But clearly smoking is a major contributor to rheumatoid arthritis. It's also been associated with double-stranded DNA autoantibody production in lupus. Interestingly, and there's some other similar sorts of exposures. Proximity to major highways has been associated with risk of autoimmune diseases, including rheumatoid arthritis as well. So the particulate pollution plays a role.
Just major highways in general, not some particular major highway.
The one closest to your house, Dan. No, yeah, some really cool studies that look at distance to major roadways and have demonstrated strong associations. So, yeah.
My goodness.
Yeah.
All right. Well, here's one for Dr. Holland. Have you looked at any correlation between anti-cytokine antibodies and long COVID? Can the presence of anti-interferon antibodies be used as a predictor of disease as patients are admitted to hospital with COVID?
Ask me in a couple of months.
All right. Well, we will. Okay. So let's see. Okay. Here is one that probably could be addressed by either Dr. Holland or Dr. Criswell. Can you comment on the relation, risk or benefit, between lupus and other autoimmune diseases and COVID vaccination?
Well, if you have an autoimmune disease, it's important to receive a vaccination. There are cohort studies that are looking at vaccination response, which of course can be diminished in the setting of treatment and immunosuppression. So that's one of the challenges associated with autoimmune disease and immunosuppressant is the poor response to vaccination. I'm less able to speak to differences in adverse events, for example, among large numbers of vaccinated individuals who do and don't have autoimmune disease. Steve is probably in a better position to answer that one.
I don't think I've seen too much that suggests to me that diseases like lupus are being exacerbated by vaccination. In contrast, I think most people that have sort of twitchy immune responses in general get into a lot more trouble with infection than they get with the vaccine. There's no question the vaccine is an immune activator, and there's no question that people feel lousy and all that stuff, which is, evidence that it's working. But the virus infection can really trigger much more severe reactions. And I think that study from PJ Uhl's group at San Francisco, that was the last data slide I showed, suggests that this infection, that the virus infection can trigger quite a bit of autoimmune reactivity. This broader question of exactly which autoimmunity does it trigger and which one persists and which one becomes symptomatic, that's a much more complex question. And what we're trying to do is to look in long-term patients to see, exactly which autoantibodies are coming up. I don't think it'll be around the anti-interferon autoantibodies, but autoantibodies against lung tissue, gut tissue, skin. These are all going to be important factors in some of the long-term sequelae of COVID-19.
Yes. I think that's a very good point. And going back to Jennifer's story, if I'm remembering correctly, a year before she was diagnosed with lupus, she had chickenpox, I guess it was. So there, a viral infection, not that she received a vaccine a year before developing lupus. But certainly that's an important point, and just the whole idea of the type and degree of stimulation of the immune system that might be associated with the development of an autoimmune disease. Okay, so now we just have a whole bunch of questions here. Well, here's one. Is there any evidence for certain viruses triggering gastrointestinal inflammatory diseases like Crohn's disease? Would there be any evidence that viruses, now of course Crohn's disease is maybe not exactly in the category of lupus, but any thoughts with regard to environmental exposure and Crohn's disease?
Well,
right.
I just say, I think Crohn's, so if we lump inflammatory bowel disease together, is there evidence for infections being important triggers? Oh, yeah. And I think the evidence is much stronger for ulcerative colitis than for Crohn's, but the evidence for microbiome effect, the evidence for changes in inflammatory bowel disease rates by location is very, very strong. Now, it gets confusing, as we were talking about earlier. We've got 15 or 115 variables all being moved around at the same time. Infection is certainly one of those, but infection, pathogenic microbes, commensal microbes, viruses, all of these are happening in all of us all the time. So trying to sort out which one is the causal one is hard, but I think that we'd all agree that environmental influences are critically important in the rates of inflammatory bowel disease. And what exactly it is that's been changing over the last 50 years to drive the rates of inflammatory bowel disease at least in the Western world, through the roof. That's not an evolutionary effect. That's an environmental effect. But exactly which environmental effect, I'm not sure yet.
Okay. All right. Well, thank you for that. Okay. So now we have a question coming back to Jennifer, if she's ready for taking another question here. The interrogator first thanks you for sharing your story. Do you have suggestions for how we as healthcare providers can do a better job communicating the research opportunities available for patients? It sounds like you are an educated consumer, but there are many who do not understand how to navigate clinical trials and research opportunities.
Mm-hmm. I'll say I've certainly become an educated consumer, but it is I make a living translating clinical content into plain language, including research content. So it should be done, period, especially if you want to reach patients. I think that having research information come from a trusted source is a huge advantage. And that can be from, for example, how I enrolled in Dr. Criswell's studies. My rheumatologist suggested that. So utilizing the network of providers to support research and encourage patients. Another way to do that would be through patient advisory groups. I see a lot of recruitment happening now via social media, Facebook, etc. Back in the day, that was, those were direct mail campaigns. Those are highly impersonal. My very favorite recruitment tactic is to have enrolled patients go out and speak to a friend who they know has lupus, or maybe through a church group, people who are trusted, whether it's someone with the condition or someone in the community. And I know back when Dr. Criswell and I were working together, we spent a lot of time in small towns around the country going to local support groups so that people could meet her face to face, ask questions, and then we would enroll those who were interested. So I think trust still remains sort of the foundation for a robust enrollment campaign.
Yeah, absolutely. Okay, well, thank you for that very insightful comment. So here's a very hard-nosed, tough question for Dr. Criswell. Why is it useful to have a blanket diagnosis of lupus, given the heterogeneity in genetic and epigenetic etiology and clinical manifestations? Why even use the word lupus anymore? That's what the questioner wants to know.
Yeah, that's a great question. And that, there's this phrase, are you a lumper or a splitter, right? So that's definitely lumping as opposed to splitting. And my hope is that with greater understanding of the underlying causes, we can, split into homogeneous subsets. And that's an overarching goal of etiologic studies, of genetics, epigenetics, et cetera. Because to the extent that those reflect differing biology, that's got to be related to therapeutic approaches, response to treatments, outcome. But it has been, most human diseases are complex. It is really difficult to define the appropriate etiologic group when you're talking about a complex disease. Now, if you're talking about a single gene disorder with 100% penetrance, that's one thing, but garden variety lupus is very different. So, these criteria exist because there's a lot of correlation within individuals in these manifestations. So they seem to co-occur, they co-occur in families. So they're related. And there are some similarities in response to therapeutic approaches across folks with these different manifestations. But, I appreciate the question because I think where we need to get is, a greater understanding of the molecular basis and better definitions of disease that relate to therapies.
Mm-hmm.
If I may jump in, I just want to say that what Dr. Criswell just said, if we can get there, it would avoid situations like the one I was experience where we'll know in a year whether you'll make it or not. That kind of unknown, everyone falls in one bucket. I hope that we can get there. And I think that's, from a patient experience standpoint, I think there are distinct advantages to continuing down the path of the understanding what buckets exist.
Mm-hmm. So that maybe 10 years from now, 20 years from now, or whatever, we'd be able to split a little bit anyway, rather than lump everything. That's what you're intending to say. Is that right?
I would certainly hope so.
Uh-huh. Yeah, and certainly, I mean, there's every reason to believe, given all the things that you guys have talked about, that there will be opportunities to make some of those distinctions. All right, so here's a question for Dr. Holland, and this is a question, I'm sure he'll turn this right back on me, but this is a question from Mark in the audience, who wants to know, Dr. Holland, is the incidence of environmentally induced immune reactions different now than, say, 150 years ago?
You know, I was going back through my Rolodex to see what I was doing on that day 150 years ago. I think I look pretty good, actually, considering. I think this is a really important question. And let me just say, number one, I actually wasn't there. But number two, the problem is that we're only as good as the records we have. And I think most of us believe that things like inflammatory bowel disease, atopic dermatitis, some of the autoimmune conditions, allergies, peanut allergy, I think most of us believe that those things are increasing in frequency over the last few decades. I remember I was at a meeting in Zambia just a couple of years ago, and one of the immunologists from Zimbabwe was commenting on the fact that over the last 10 years, he had seen allergies to things that he'd never seen allergies to before. Peanuts, potatoes, things that were staples of the Rhodesian diet or the Zimbabwean diet that had not been causing trouble up until something changed. Now, what that was, I don't know if it's tobacco or Twinkies or what, but it's something that we've got here as well. And so I think that the changes over the last 150 years are very hard to sort out. The changes over the last 30 years are easier to sort out, and they're quite dramatic. And I think this is where we're all having trouble figuring out, is this a microbiome change? Is this an ingestion change? Or maybe those are one and the same. You know, maybe if you eat a lot of Twinkies, your microbiome, maybe it's twinked. So I think we're all going to have to sort out over the next few years exactly what are those exposures that are leading to this. But it's clearly environmental. We just don't know which part of the environment it is.
Yeah, that's a very good point. A very good point. So I think we're getting close to the end here, but here's a good question for Dr. Criswell. Why is there a predominantly female predisposition to develop lupus?
Yes, and it's very striking. One of the most striking among the autoimmune diseases, and there are several lines of evidence that implicate hormonal factors, including, when lupus tends to occur over the course of a lifetime in relation to, hormonal factors. There are genes on the X chromosome that have been implicated in lupus, both from a genetic standpoint and an epigenetic standpoint. Along those lines, one of the types of studies that I find most interesting are studies of folks that have abnormal karyotypes, abnormal sex chromosome stereotypes. For example, individuals with Turner syndrome XO or Klinefelter's XXY. And in those individuals, their risk for lupus relates to the number of copies of the X chromosome they have, not necessarily their general phenotype. So Klinefelter phenotypical males have increased risks of lupus, more comparable to lupus. Turner syndrome females have decreased risk of lupus, more similar to males. And so clearly, dosage of genes on the X whether it's because of inheritance of additional or a copy of the X, or problems with X chromosome inactivation are part of that explanation. I mean, a tougher question might be why, not all autoimmune diseases show this female predisposition. The spondyloarthropathies, for example, are different. But anyway, I think between hormonal factors and genes on the X chromosome, that goes a long way to explain the female predominance for lupus.
Yes, indeed. Well, at this point, we are down to our last minute and 20 seconds of the 2 hours. And so I think that at this point, we should probably bring things to a close. I, again, want to thank Jennifer for making herself available. This has really been fantastic, having the voice of a patient here to really put everything in perspective. I thank Dr. Criswell for a wonderful lecture, and Dr. Holland for a wonderful lecture, and all three for entertaining questions and really being very nimble in their approach to all of the different questions that have been posed to us. So with that, I think we'll call it to a close. Thank you again very, very much. Thank all of the participants, the audience, the questioners, and we look forward to a whole new audience that will be viewing this over the course of the next weeks in the video cast. So again, thank you all very much. Have a good evening, everyone, and we'll look forward to seeing everyone back again next Tuesday afternoon. Thank you.
Thank you.
Thank you, Dan.
Don't hang up, don't hang up, don't hang up, just leave it down.
Bye-bye.